editorial board, the contributors, and the Johns Hopkins University are not endorsing the products of the sponsors in the paid announcements which now follow.
Among the many technological advances in surgery achieved over the past 2 decades, few have added more to increased efficiency and reduced OR per patient time than the development of the modern vessel ligating clip for enhanced access with convenient delivery to the field. Since its introduction in 1963, the distinctly free-formed hemoclip ligating clip from Edward Weck and Company has spelled unmatched precision and widest vessel engulfing action. Use of unique heart-shaped wire is specifically designed to deliver the closure security surgeons demand and expect. The unique advantages of the hemoclip ligating clip have just been extended and enhanced by the availability of the new hemoclip automatic system. This precision feed applier provides for the first time fully automatic clip feed to the point of placement. Dropped clips and loading distractions are virtually eliminated. A total ligating clip system and a total commitment from Edward Weck and Company.
With one of the most advanced manufacturing facilities in the world, Astra continues a commitment to excellence begun over 35 years ago with xylocaine. Astra has earned a special reputation for the highest quality products with stringent quality controls, and for ongoing international research, which has provided more than 50 forms of xylocaine. And now, the new xylocaine or sensorcaine sterile pack for the sterile field. Next time, specify Astra, xylocaine, or sensorcaine. Astra Pharmaceutical Products, a commitment to excellence.
One new medicine can save 1 million lives or keep millions of people healthier. DuPont Pharmaceuticals' goal is to make medicines that make our lives better. DuPont products currently include Coumadin, Narcan, Simitrel, Hycomine, Percodan, Nubane. The list goes on. Because at DuPont, the search goes on to help doctors do more than ever before for their patients. Pharmaceuticals from DuPont. Better things for better living.
Welcome to this edition of SurgSat. This is the second in a series of programs on options in the diagnosis and management of breast cancer. In the first program, we discussed mammography and its role in the detection of early breast cancer. In addition, the staging of breast cancer by clinical and histologic criteria was described, as well as the role of staging in predicting prognosis. Most surgeons who treat breast cancer spend far more time managing fibrocystic disease of the breast than in managing breast cancer. That's because most women who are referred to a surgeon for evaluation fortunately do not have cancer, but have benign fibrocystic breast disease. Our first speaker today, Dr. R. Robinson Baker of the Johns Hopkins Hospital, will discuss the clinical management of fibrocystic breast disease and the role of outpatient biopsy.
Breast complaints probably bring more women to the general surgeon than any other condition. The majority of these complaints are caused by benign disease, but the motivation to seek medical attention is almost always related to an underlying fear of cancer. Although these patients frequently have relatively insignificant complaints and physical findings, the surgeon is obligated to perform a careful clinical assessment in order to rule out the possibilities of a malignant tumor. This clinical assessment should also be designed to obtain some estimate of the patient's chances of developing breast cancer. Therefore, in addition to a detailed history of the complaints referable to a breast, the patient should also be carefully questioned as to a family history of breast cancer, age of her children, onset of menses, and onset of menopause if it has occurred. Cyclical swelling of the breast associated with varying degrees of pain and tenderness are the most common complaints one encounters. These symptoms may or may not be associated with focal areas of tender, indurated nodular breast tissue. In some cases, these clinical findings are due to a relative excess of estrogen, but genetic factors, abnormalities in prolactin secretion by the pituitary gland, and abnormalities in the level of circulating non-gonadal hormones probably also play some role in the production of these clinical findings. As previously noted, the clinical findings of pain, swelling, and tenderness associated with nodular breast tissue are remarkably common and occur to some degree in almost any woman during some phase of her menstrual career. Similarly, the histologic findings, which have been classified under the general heading of fibrocystic disease, are present in 95% of women in autopsy series. It would probably be more logical to refer to these clinical and pathologic findings as a condition rather than a disease, but the term fibrocystic disease has been firmly rooted into the medical literature. The pain, swelling, and tenderness can be associated with physical findings which are quite alarming. One or both breasts may contain large focal areas of tender, indiscrete, nodular breast tissue, which is suggestive of a malignant tumor. In contrast to the induration of malignancy, however, the breast tissue is usually tender on palpation, and the degree of induration varies with different phases of the menstrual cycle. The induration is maximum just prior to the menstrual period and subsides once menses occurs. It is important, therefore, to examine these patients in different phases of the menstrual cycle, preferably just after menstruation, and to not make any clinical decisions on the basis of a single examination just prior to the menstrual period. The majority of such patients do not require further diagnostic studies or treatment. In the absence of any significant risk factors, routine follow-up visits are probably all that is necessary. In an occasional patient, the physical findings cannot be delineated from the physical findings due to a carcinoma, particularly if they are persistent, unilateral, and restricted to one focal area in the breast. Mammograms may be helpful in ruling out the presence of malignancy in some cases, but these x-rays are not particularly sensitive in younger women with dense breast tissue, and one is reluctant to expose women under 35 to irradiation. A percutaneous needle biopsy or biopsy through a limited circumarelar or circumferential incision in the periphery of the breast may be necessary in a few patients in order to rule out the possibility of a malignant tumor. The pathologic findings in this type of clinical situation are variable. Fibrous mastopathy and focal areas of sclerosing adenosis are the more characteristic histologic findings, but not necessarily the cause of the clinical findings. In some cases, rather severe symptoms and induration are associated with essentially no histologic evidence of so-called fibrocystic disease. In the past, some of these patients have been treated by subcutaneous mastectomies performed through a limited inframammary incision and followed by simultaneous silicone implants to restore breast contour. Enough experience with this type of operation has been obtained for adequate evaluation. This operation is not an effective means of treatment because it fails to remove all of the breast tissue and therefore fails to relieve all of the symptoms. If all the breast tissue is removed, focal areas of the skin and nipple are devascularized, and there is an appreciable incidence of skin slough either initially or as a later complication. Subcutaneous mastectomies are not, therefore, an acceptable method of treating patients with symptoms secondary to so-called fibrocystic disease of the breast. As previously noted, the symptoms of so-called fibrocystic disease are probably due to a relative imbalance of estrogen in relation to the amount of progesterone, either too much estrogen or too little progesterone. Medical therapy has therefore been designed to change the hormonal environment, either by changes in the diet or with the use of exogenous drugs. A number of investigators have tried large doses of vitamins in an effort to relieve the cyclical pain, swelling, and tenderness, as well as the nodularity of the breast tissue. Vitamin A may antagonize estrogen production by the ovarian follicle, while vitamin B increases hepatic detoxification of estrogen. Both of these vitamin preparations have been described in the treatment of fibrocystic disease, but their effect is variable and has never been evaluated in a controlled clinical trial. Vitamin E has been the most popular vitamin preparation employed and has also been the most extensively investigated. There is some evidence that large doses of vitamin E may have some effect on steroid metabolism in the adrenals and/or ovaries, and thus may decrease the estrogen stimulation of the breast. There is suggestive evidence that vitamin E is effective in relieving symptoms of fibrocystic disease, and vitamin E is presently being investigated in several prospective double-blind studies. It may or may not have some effect on cyclical pain, swelling, and tenderness in the breast. In the dosage recommended, 600 milligrams a day, there has been no significant toxicity. Several years ago, Minton and his associates proposed eliminating methylxanthines from the diet as a means of relieving the symptoms of fibrocystic disease. Methylxanthines are thought to have some effect on intermediate metabolism and to increase circulating catecholamines, which in turn were thought to have some effect on the development of fibrocystic disease in the breast. Methylxanthines are found in relatively high concentration in coffee, tea, and cola drinks. Although Minton's initial reports were encouraging, several other investigators have failed to confirm his work in carefully controlled studies, and there is no evidence at the present time that restriction of methylxanthines really has any significant effect on the pain, swelling, and tenderness in the breast or on the physical findings associated with these complaints. Another approach has been the use of hormones such as progesterone, estrogen-progesterone combinations, androgens, and thyroid extract. All of these compounds have some temporary effect, but there has never been any controlled study evaluating their use, and they are probably of limited practical value. Hormone inhibitors do have some effect in patients with fibrocystic disease and can be employed in selected patients with severe persistent symptoms. Danazol, an inhibitor of pituitary gonadotropins, inhibits the mid-cycle surge of luteinizing hormone and follicle-stimulating hormone, and in some cases inhibits ovulation. It also may lower prolactin levels. I would recommend an initial dose of 50 milligrams a day. This drug has relatively few side effects at the dosage recommended. Tamoxifen, an anti-estrogen, competes with estrogen for estrogen receptor sites in the cytoplasm of the breast cells. This drug will also relieve the symptoms of pain, swelling, and tenderness in the breast. A dosage of 10 milligrams a day is recommended. Tamoxifen may produce menopausal symptoms, which the patient finds as annoying as the breast symptoms. The definitive management of the patient with a discrete mass in the breast is considerably easier than the management of the patient with complaints of pain, swelling, and tenderness associated with indiscrete focal areas of indurated breast tissue. In any patient with a discrete mass in the breast, a histologic diagnosis should be established. The mass should be excised or aspirated regardless of the radiographic appearance, and therefore mammograms are